Okay, so hi friends, hi everybody. I'm Dr. Sushant Soni, MBBS PAMC, MD Pathology, Resident Hemat-Oncology, AIMS Delhi. And it's an honor for me to share the stage with Anupama ma'am. I guess physio faculty with the longest ever experience, 25 plus years. I know हम लोगों की इतनी age नहीं है जितना ma'am का experience है, I guess. And ma'am, let's start with our integrated path physio lung session.
So just a brief introduction, I'm Dr. Anupama. I am the physiology faculty at Next, and this is my 18th year teaching students preparing for neetpg for the INI-CET and the FMG exams. And integrated sessions have become extremely important. The fact that you can integrate this is what is called a vertical integration. So physio today is being integrated with path. Extremely important because now the kind of questions which are being asked, as you would agree, Dr. Sushant, is sort of an integrated pattern. So that's exactly what we are going to focus on today. And today we are going to focus on the obstructive and restrictive lung diseases. This is such a favorite topic of all the examiners. Whichever exam that you talk about, there are invariably questions which come from this topic.
So I guess it is favorite because we are, as MBBS students, especially the physio, all those curves, they are hard to understand.
Yes.
So
let's start with that. So a little brief introduction about the obstructive lung diseases and the restrictive lung diseases. So when I say obstructive lung disease, that means there is an obstruction to flow, and restrictive lung diseases means there is a restriction in lung expansion, very simply. Now, what are the differences between these two? So firstly, I will just enumerate the differences and explain these to you. Now, when you look at the total lung capacity is increased in obstructive, reduced in restrictive. Residual volume, this is increased. There is more air trapping in obstructive lung disease, and this is reduced in restrictive, except in the extrapulmonary causes. I will discuss that with you. When you look at the forced vital capacity, this is normal to reduced in obstructive, whereas in restrictive, definitely reduced. If you look at FEV1 by FVC ratio, which is also called the timed vital capacity, this is reduced in obstructive lung disease, and this is normal to increased in restrictive lung disease. PEFR, peak expiratory flow rate, this is reduced in obstructive, less affected in restrictive. MEFR, mid-expiratory flow rate, again reduced in obstructive, less affected in restrictive lung disease. And what about diffusing capacity? Diffusing capacity is normal in obstructive except in emphysema. And this is definitely reduced in the restrictive lung disease. The point I'm trying to make is, when you look at these first three, these are volumes. The remaining are rates. So in obstructive lung disease, the rates are affected more than the volumes because there is obstruction to flow. So a rate will be affected more as compared to volumes. But if you look at restrictive lung disease, where there's a restriction expansion, the volumes are affected more than the rates. Total lung capacity, residual volume, forced vital capacity, these are volumes affected more in restrictive. FEV1 by FVC, PEFR, MEFR are rates. These are more affected in obstructive lung disease. So a little bit about the timed vital capacity. Now, when I look at vital capacity, how do we measure vital capacity? Now, vital capacity this is a tidal respiration which is going on. I ask my patient to take a maximum inspiration, a deep inspiration, and we ask this patient to breathe out forcefully, maximally, with maximum possible effort. This volume of air which he expires forcefully after a forceful inspiration is known as the forced vital capacity, or sometimes simply known as vital capacity. Now, what is timed vital capacity? Now, if I want to bring time into the picture, what are my instructions to the patient? Maximum inspiration followed by maximum expiration, but that expiration has to be done as fast as possible. I'm bringing time into the picture. Now, timed vital capacity is FEV1, FEV2, and FEV3. FEV is forced expiratory or forcefully expired volume of air. One here stands for at the end of 1 second, then at the end of 2 seconds, at the end of 3 seconds. Surprisingly, Dr. Sushant, there was a question in the INI-CET exam that in FEV1, FEV2, and FEV3, what does 1, 2, 3 stand for? It is at the end of 1 second, 1 minute, 1 hour, 1 day. So this was an INI-CET question, which would have been a cakewalk. So this is your FEV1, FEV2, and FEV3. So how do we record that? Now, this is the patient's tidal respiration which is going on. We ask him to take a maximum inspiration followed by a maximum expiration, but the expiration is being done as fast as possible. And we start measuring the time. Now, the time will be measured from the point where he begins to expire. So from this point onwards, I start recording the time. So this is 1 second, 2 seconds, 3 seconds. Now, what is FEV1? I will extrapolate this point and take it onto the graph. So this is the volume of air expired at the end of 1 second. Now, this is expressed as a ratio, and it is normally expressed as a ratio of the forced vital capacity. So this has to be 0.7 to 0.8, 70 to 80%. That means at the end of 1 second, a normal individual should be able to breathe out at least 70% of his total vital capacity. So if I ask you a question, forced vital capacity is 5 liters, what should be the volume of air expired at the end of 1 second in a normal individual? So at least 70% of 5 liters, which is 3.5. So similarly, if I want the FEV2, I will extrapolate this point and I will measure this volume. This is FEV2. Again, FEV2 will be expressed as a ratio of the total vital capacity, and this should be 0.9 or 90%. And similarly, we can also take FEV3. FEV3, at the end of 3 seconds, a normal individual should be able to breathe out almost his complete vital capacity. So FEV3 by FVC ratio is 0.97 to 0.98. So this is what is the timed vital capacity. And like I told you, in obstructive lung disease, the FEV1 by the FVC ratio is definitely reduced. Now, how does a ratio decrease? Now here, the forced vital capacity is normal to reduced, but the FEV1 is markedly reduced. The numerator has decreased more than the denominator. So therefore, there is a decrease in the ratio. When you look at the restrictive lung disease, FEV1 by FVC, this is normal to increase. Now, how is a ratio normal? If the decrease in the numerator and the denominator is to the same extent. So the ratio is normal. How does the ratio increase if the decrease in the denominator is more than the decrease in the numerator? And that's exactly what happens in restrictive lung disease. Because there is a restriction and expansion, the FVC reduces more than the FEV1. The ratio will increase. So this is as far as the timed vital capacity is concerned. Now, as you can see over here, this is again a graph which is showing you the time vital capacity, exactly what we have just discussed, and what happens in a obstructive and a restrictive lung disease, already discussed. Now, a little bit about what do you understand by a flow volume curve or a flow volume loop. Let's try and understand that. This is also a very important investigation, especially when you're trying to rule out or trying to distinguish between obstructive and restrictive. Now, what happens here is we take The lung volume on the x-axis. This is in liters. So I'm going to talk first about an expiratory flow volume curve, and then I'll tell you what is a loop. Now, expiratory flow volume curve, we will take lung volume on the x-axis. So from left to right, it is a decreasing lung volume. So if this is 6 liters, this is 5, 4, 3, 2, 1, and 0. You are expiring. So lung volume is reducing. And what do I take on the y-axis is what is known as the expiratory flow rate. Now, this expiratory flow rate, now remember, this is a rate, and rate is always per unit time. So this is 100, 200, 300, 400. So this is in liters per minute. So when I say expiratory flow rate, literally means the speed with which the air is flowing out of the lungs. So now what we see is, how do we record this expiratory flow volume curve? We'll tell our patient to take a maximum inspiration. Maximally, he has to inflate his lungs to the maximum possible capacity. So what is his lung volume at the end of a maximum inspiration? That is the total lung capacity. So he starts this maneuver from total lung capacity, which is 6 liters in males and 4,200 ml or 4.2 liters in females. So he starts from total lung capacity. Now we ask him to breathe out forcefully and as fast as possible. Now he breathes out into a very special type of a spirometer. It's a computerized spirometer, which will record the expiratory flow rate. So what do we find? When he begins to expire, there is an increase in the expiratory flow rate, 100, 200, 300, 400 liters per minute. This is now known as the peak expiratory flow rate, and this part of the curve is known as the effort dependent part of the flow volume curve. He's exerting effort, he's using his strength to breathe out forcefully, and the expiratory flow rate increases. But once it reaches this peak expiratory flow rate, he's using effort to expire forcefully, but the rate, instead of increasing, starts decreasing. And now this is what happens. And by the time he reaches his residual volume, now of course, 0. The expiratory flow rate is 0. So my next point is, this is known as the effort independent part of the flow volume curve. Now, why is this an effort independent part? He's using his effort to breathe out forcefully, but the flow rate, instead of increasing, has started decreasing. So what is the reason for this decrease in flow rate is what is known as a dynamic compression of airways. And what is this dynamic compression of airways? When you breathe out forcefully, the non-cartilaginous airways, not the cartilaginous airways, the non-cartilaginous, because you must understand, cartilaginous airways are like rigid tubes, but the non-cartilaginous airways will tend to collapse. It's like when water is flowing through a pipe and you put your foot on it, what will happen to the flow rate? Reduces. That's exactly what's going to happen, what is known as dynamic compression. During a forceful expiration, these non-cartilaginous airways will tend to collapse. And if they tend to collapse, what will happen to the flow rate? Flow rate will start reducing. And at the end of a forceful expiration, the airway collapse is complete. Air is trapped in the alveoli, which is known as residual volume. Now, what is the width of this curve equal to? The width of this curve will be equal to total lung capacity minus residual volume, that is forced vital capacity. Now, so a very simple question. Peak expiratory flow rate is effort dependent or effort independent? This is going to be effort dependent. Now, there is another term which is called mid-expiratory flow rate. And this is also known as FEF, forced expiratory flow rate, between 25 to 75% of vital capacity. So that means when you look at the width of this loop, which is vital capacity, if I divide this into 4 parts, this is 50% of vital capacity, this is 25% of vital capacity, this is approximately 75%. So if I want forced expiratory flow rate between 25 and 75% of vital capacity, we will extrapolate this point. You will get these rates between 25 and 75% of vital capacity. Take an average and you get what is known as the mid-expiratory flow rate. We don't have to do it. The computer does everything. So now my next question, which is again a question which has been asked. Mid-expiratory flow rate is effort dependent or effort independent? This is now an effort independent. It's a very sensitive parameter to measure early bronchial asthma. We prefer MEFR even over FEV1 by FVC. A very sensitive indicator of small airway disease. So this is your effort independent. This is what is your expiratory flow volume curve. Now, what is going to happen in obstructive lung disease? So if this is my normal expiratory flow volume curve, the curve that I get in obstructive lung disease is something like this. What has happened? Total lung capacity has increased. Remember, from left to right was 6543. So if this is to the left of normal, this is going to be a higher total lung capacity. Residual volume has increased. More air trapping, early collapse of airways. Forced vital capacity is, in this case, reduced. It can be normal to decreased. But what is important is the PEFR has reduced. But look at this. The shape of the curve itself has altered. This is what is known as a scooped out curve. You're taking an ice cream scoop, so it's a scooped out curve. It's also known as a coved curve. Cove, it's like a cave. Why is the shape of the curve abnormal? This is because of an early collapse of airways. So this is what you see in a typical obstructive lung disease. Now, just one more point, and then I'll hand it over to you, Dr. Sushant, and that is what is a loop. So I've just spoken about the expiratory flow volume curve. We start from total lung capacity, end at residual volume. This was expiration. Now, when the lung volume is at residual volume, I ask the patient to take a maximum inspiration, and now the spirometer will record the inspiratory flow rate. So now we ask him to take a maximum inspiration, and this is the inspiratory curve. He will end this at total lung capacity, so this becomes a loop. Now, inspiratory curve does not have that effort dependent and effort independent part. It is a more uniform curve. And number two, the height of the inspiratory and the expiratory curves are nearly the same. So this is what makes it a loop. So expiratory flow volume curve and a flow volume loop. What happens in obstructive lung disease? Important things that you've just learned, and that is increase in total lung capacity, increase in residual volume, forced vital capacity in this case is reduced, PEFR is reduced, and MEFR is markedly reduced, which has given rise to what is known as a scooped out curve. Dr. Sushant.
Actually, beautifully explained, ma'am. No doubt about this. And if you'll allow, actually, I'll carry forward from this slide only, because this slide is the gist of pathology also. This is what we mean by physiopath integration, in the sense that when in pathology, when we talk about the obstructive lung diseases, you know this extremely well, that in path, we divide them into 4 main categories. That is emphysema, chronic bronchitis, asthma, and bronchiectasis. We do so because the pathology is different. versus medicine people, which divide them into COPDs, chronic obstructive pulmonary disorders, versus asthma, because they consider COPDs as irreversible, asthma is reversible. Fair enough, fair enough. Now, the point to be noted here is emphysema is irreversible dilatation of the acinus. The acinus is getting irreversibly dilated. I'm sure you know this. It is irreversible dilatation. So acinus has air inside it. Problem kahan hai? As ma'am has beautifully explained, the problem is in expiration. So this is called as pink puffers. The patient is pink. He is not cyanotic, firstly, and he is puffing. Lambe lambe saans le raha hai. He is puffing because there is a problem in expiration, as is explained in this diagram. That is why there is presence of a scooped out curve during expiration. Firstly. Secondly, the acinus were dilated. They were dilated. So the peak expiratory flow rate, it was an obstructive lung disorder. So peak expiratory flow rate was reduced. So pathology integrates beautifully with physiology. Next, versus chronic bronchitis. B say bronchitis, B say blue bloatus. Chronic bronchitis is called as blue bloatus. The first thing that comes to our mind when we talk of chronic bronchitis is excessive sputum production for 3 months for 2 consecutive years. For 2 consecutive years. That is chronic bronchitis. So, with respect to the NEET PG exam, I'm not going to the INI questions as of now. Which index is used in chronic bronchitis? Reed's index. Reed's index is more than 0.4. Reed's index was the ratio of thickness of mucus gland layer. See, sputum production is increasing, so the mucus gland layer is increasing. The mucus glands are undergoing hyperplasia. So, mucus gland layer to the thickness of wall between epithelium and cartilage. Thickness of cartilage was not included. So, B upon A plus B plus C. I'm sure you know this from pathology part. Next obstructive lung disease is asthma. Recent PYQs, I guess previous 3 years, we've had 5 questions from this. So I'll quickly just one line which has been repeatedly asked. Which is the main cell? You very well know it is type 1 hypersensitivity. So I'm not getting into the details of it is the immediate type of hypersensitivity reaction. Main cell associated with asthma is, we sometimes mistake it to be the eosinophil, but bache, the main cell is mast cells, followed by eosinophils, basophils, and T cells. So, first question, NEET PG 2019, stain used for mast cells. Stain used for mast cells, toluidine blue. Next question, AIMS November 2019 asked you, which is the main activator of basophils? B is the second alphabet. So interleukin 3 followed by interleukin 4. 3 was not given in the options, interleukin 4 had to be marked. That was November INI. 2 months after that, NEET PG happened and they asked you main activator of eosinophils. E is the fifth alphabet, A, B, C, D, E. Interleukin 5 followed by 4. So again, 5 was not in the options, 4 had to be marked. So back to back 2 papers, November AIMS followed by NEET PG, both the answers to be marked was interleukin 4 for basophils as well as eosinophils. Next, lastly is bronchoectasis. Ectasis is dilatation. It is irreversible dilatation. Bronchoectasis is irreversible dilatation of bronchi and bronchioles. So what is the difference between emphysema and bronchoectasis? Emphysema, as ma'am beautifully explained in this diagram, is a small airway disease. It is affecting the acinus. That is why it had a scooped out curve. So emphysema is an obstruction of small airways versus bronchoectasis, which affects bronchi and bronchioles. That is, this is a proximal airway disease. And I guess on curves also, I can see ma'am grinning and desperate to say how we differentiate.
No, just carry on, please. I'll just.
Okay, so these are the four categories of obstructive lung disorders. So I just wanted to show you 2-3 images before I hand over to ma'am. Now, the minute we see this, I'm clearly able to make out that these are the thin-walled alveolar septa. They have air inside it, making the parent tissue as lungs. Diagnosis. Can I say emphysema? No. This is the normal pathway, that is the terminal bronchiole, alveolar duct and sac, this is a nice normal lung. Differentiate normal from one of our favorite topics, that is emphysema. Dekho, firstly have a look at this. All these are the alveoli which have air inside it, making this as a nice normal lung. Differentiate this from the emphysematous areas, that is irreversible dilatation of the acinus, along with collapse of alveolar septa, that is emphysema. Emphysema, it is of 4 types. Let's quickly have a look at those 4 types also. Centriacinar emphysema, centriacinar, panacinar, panacinar, paraseptal, paraseptal, and irregular emphysema. So emphysema is of 4 types: centriacinar, panacinar, paraseptal, irregular. Which is the most common emphysema? Irregular. Most common, irregular. But point to be noted here is it is detected at autopsy. So is it clinically significant or non-significant? It is clinically non-significant. The patient never went to the doctor. It is clinically non-significant. Whereas the most common clinically significant emphysema, accounting for more than 95% cases, is centriacinar. So if the patient is coming to your OPD with pink puffer clinical features, chances are extremely high it is a case of centriacinar emphysema. And what is the main predisposing factor? Nothing is worse than smoking, guys. So I mean, no doubt about it. Main risk factor being smoking. Now, I'm sitting with ma'am, so I'm not going to say that when we inhale air, more air goes to apex of the lung. We know that from physio. So location, more smoke also goes to the apex of lung, and which is the uppermost part of the lung, that is the apical and posterior segments. Location being apical and posterior segments of upper lobe of the lung, of upper lobe. This is centriacinar. Versus panacinar, the whole acinus is involved. It settles down. Lower lobe of the lung is involved. This is lower lobe, and this is the one which is associated with alpha-1 antitrypsin deficiency. So if I have to look at it grossly, just have a look at this image. Lung is like sponge. I mean, all of us, especially the guys, I'm not going to say who are in live-in, but hum sabne bartan to dhoye hain ek aad baar. So that is what a fresh lung sample looks like. We can squeeze the lung sample. So this is nice normal lung with interspersed emphysematous areas. With interspersed emphysematous areas. That is centriacinar emphysema. Versus, have a look at this. The whole lobule of the lung is involved. Panacinar. The images, they are totally different from each other. And lastly is the paraseptal emphysema, in which the upper half of the lung is involved, and it shows emphysematous areas present subpleurally. It is present just below the pleura. So what is the clinical significance of this? These emphysematous areas, they can spontaneously rupture, leading to pneumothorax. So paraseptal emphysema is associated with spontaneous pneumothorax. This is paraseptal. So this was just an attempt at emphysema, that is an obstructive lung disorder, and correlating it with our loops, that is having a look at this. This was obstructive lung disorder.
Thank you for brushing up my pathology knowledge as well, and very well explained. And there's one point which I thought I could add, and that is from a physiology point of view. Sir told you about how there are these dilated acini, and I told you diffusing capacity of the lungs is reduced in emphysema. And herein you have to look at the Fick's law of diffusion. What is the Fick's law of diffusion? J is equal to minus dA delta C by delta X. Very often asked question. D is the diffusion coefficient. A is the surface area. So if the surface area which is available for diffusion reduces, the diffusing capacity will automatically reduce. So what has happened in the case of emphysema? If this is my normal alveolus, emphysematous lung has these dilated alveoli with departitioning, the breakdown of alveolar septa, which reduces the surface area and reduces the diffusing capacity. So emphysema is the lung condition, obstructive lung disease with a reduced diffusing capacity. Now, can we go on to restrictive lung diseases as well? Okay. So let's have a look at the flow volume loops or the flow volume curves in restrictive lung disease. Now, clinically, restrictive lung diseases can be classified into pulmonary causes and the extrapulmonary causes. Now, extrapulmonary causes will include neuromuscular problems. Neuromuscular problems like, let's say, Guillain-Barré syndrome, or maybe there is a phrenic nerve palsy, or it could be because of chest wall deformities like kyphosis, scoliosis, etc. So these become your extraparenchymal causes or extrapulmonary causes. Pulmonary or parenchymal causes like pulmonary fibrosis or pneumoconiosis or asbestosis, all these will come under parenchymal or pulmonary causes. Now, what is going to happen to the restrictive lung diseases? What is the flow volume curve that you're going to get? Now, this is my normal flow volume curve. Now, in restrictive lung disease, we find that the curve is something like this. What has happened? Restriction in lung expansion, so a reduction in total lung capacity, reduction in residual volume, width of the curve is definitely reduced. So a reduced forced vital capacity. So you've got a reduced total lung capacity, reduced lung volume, reduced forced vital capacity, but the height of the curve is less affected as compared to the obstructive lung disease. Restrictive lung diseases, volumes are affected more than the rates. And we typically describe them as a tall and a narrow curve. Tall curve, because like I said, the rates are less affected. Narrow, because the forced vital capacity is definitely reduced. So this is what you get in restrictive lung disease. But in extraparenchymal causes, the curve is going to be slightly different. The extraparenchymal causes, now this is a normal curve. In extraparenchymal causes, the residual volume increases. The patient is unable to breathe out completely, so there is more residual volume. So the curve looks something like this. A reduced total lung capacity, more residual volume. This will happen in kyphoscoliosis, in phrenic nerve palsy, a reduced forced vital capacity, and of course the height of the curve is reduced definitely, but not as much as in obstructive lung disease. So this is typically defined as curve lies within a normal curve. So where do you get a tall and narrow curve? Restrictive lung disease due to pulmonary or parenchymal causes like pulmonary fibrosis, etc. And the curve lies within the normal curve will be in restrictive lung disease, extraparenchymal causes. So this is what happens in restrictive lung diseases. Over to you, Dr. Sushant.
Perfect. So, as ma'am had beautifully classified the restrictive lung disorders into pulmonary versus extrapulmonary. Now, the pulmonary restrictive lung disorders, we can further subcategorize them into 4 categories. I'll slightly expand this.
Definitely.
That is the fibrosing restrictive lung disorders. Next are the granulomatous restrictive lung disorders, smoking associated restrictive lung disorders, and lastly is the eosinophilic type. Our main categories being fibrosing and the granulomatous. Fibrosing restrictive lung disorders. The bottom line is the same. It is occurring due to fibrosis. The main being NSIP, non-specific interstitial pneumonia. NSIP. BOOP. I know, pretty sexy name for a lung disorder. Bronchiolitis obliterans organizing pneumonia. BOOP. Also called as cryptogenic organizing pneumonia. BOOP और द क्रिप्टोजेनिक ऑर्गेनाइजिंग निमोनिया. कौन सी बॉडीज मिलती हैं BOOP में? मेसन बॉडीज. एंड लास्टली इज pneumoconiosis. These are the fibrosing type. Versus, you know this, when I talk about granulomatous restrictive lung disorders, which is the first main granulomatous restrictive lung disorder, the one associated with non-caseating granulomas with bilateral hilar lymphadenopathy, that is sarcoidosis and hypersensitivity pneumonitis. This is the classification. We'll not bore ma'am with the details and go into the extreme depths of this, but restrictive lung disorders, which is a very, very important topic, BOOP, Mason bodies, pneumoconiosis, which is further of 3 types. Acha, before I name the types for you, you tell me diagnosis. Nothing has been given to you, just this gross image is given. What are the 2 main things I'm able to see here? It is involving the lower lobe of the lung and is associated with marked pleural thickening. So diagnosis, lower lobe involved है ना, asbestosis. The first 3 are the pneumoconiosis, anthracosis, silicosis, asbestosis. Anthracosis and silicosis involve upper lobe of the lung versus asbestosis, lower lobe with pleural thickening. And lastly, let me show one last image.
Of course.
What do we see here? It is, examiner has just told you it's a lung biopsy. I'm not able to appreciate the presence of alveoli here. What I'm able to see is the presence of these dumbbell-shaped fibrous structures which are brown in color. Which pigment is brown? Hemosiderin. So these are hemosiderin-coated asbestos fibers. These are hemosiderin-coated asbestos fibers called as which bodies? Ferruginous bodies. Seen in asbestosis. Called as ferruginous bodies. Seen in asbestosis. Perfect. So I guess
Fantastic.
this takes care of
this. Such lovely slides and brushing up of your restrictive obstructive lung diseases in this short time. I hope you found this session useful. And very importantly, Dr. Sushant, now people have been talking about ignore your pre and paraclinical subjects and do only clinicals. Do you think it's possible to do medicine without doing your physiology and pathology and maybe add pharmacology to it? Impossible.
Actually, we can rephrase this. I mean, talking of the 3 Ps, I mean, no double meanings to this, but physio, the Ps that we are referring to are the physio, path, pharma. You can ignore physio. I mean, no offense, ma'am. You can ignore physio, but you can say goodbye to the less than 6K rank. This is bye-bye.
That's a catch.
You can ignore path.
Yes.
But in that case, you can say goodbye to the initial 12K rank. Ignore pharma at your own risk. And then probably things will worsen. So guys, when we are studying, it's not easy to study. I mean, let's be frank about it. Any day, even I will like to go out, hang out with friends, do crazy stuff. Ma'am will like to hang out with family and friends. But if you are studying, study with full concentration and target the top ranks. That is why we are here now. And we are in this journey together. Absolutely. I mean, there's no doubt about it.
Absolutely.
So,
Concentrate on your basics, concentrate on physiopath pharma. Medicine becomes cakewalk. And like Sir has very beautifully put it, we are in this together. And wishing you all the very best. Hope you found this session useful, and we'll be back with more.
True.
I hope you enjoyed the session as much as we did in bringing it to you. Thank you very much.
take care.
See you
And a
soon.
pleasure. Thank you, guys. Take care.